welcome to Medicine Grand Rounds. Before we begin with our presentation, I'd like to present January's Choosing Wisely data. So overall, as a department, we ordered 400 less CVCs, roughly 400 less VMPs, and had a cost reduction of roughly $16,000. So congratulations to everyone involved. Looking at the individual service winners, again, pulmonary critical care had the highest cost reduction, so congratulations to the individual residents and attendings. We have our $10 gift certificates that we will be distributing starting today. Cardiology inpatient was a close second, so I would encourage everyone in February to think before you order and choose wisely. Okay, so today we have Dr. Srinivas presenting on kidney transplantation. Dr. Srinivas joined us in the Division of Nephrology at MUSC back in 2012 as a professor and medical director of transplant kidney and pancreas transplant programs. He received his medical degree from Jawaharlal Institute of Postgraduate Medical Education and Research in India. He went on to complete his residency training from All India Institute of Medical Sciences back in 1991. He then went and performed a fellowship in nephrology at St. Luke's Roosevelt Hospital Center, followed by a residency in internal medicine at Montefiore Medical Center in 1995. Following graduation, he received his graduate certification from the University of Florida in clinical investigation. He comes to MUSC from the Cleveland Clinic, where he served as a staff transplant nephrologist. Dr. Srinivas has published numerous articles in book chapters on outcomes of kidney transplantation and immunosuppressive regimens in kidney and pancreas transplantation. He is nationally recognized for the Donor Wellness Initiative, an innovative clinical program fostering wellness among living kidney donors. Today, please welcome Dr. Srinivas as he presents kidney transplantation, opportunities and challenges.
Thank you so much. You all hear me? Okay. Thank you so much for that generous introduction. You're the first person who said Jawaharlal Institute really well, so thank you so much. Okay. All right. So for those of you who don't know where that is, it's in Pondicherry, where The Life of Pi was staged. Okay. If you've seen the movie or read the book, that's where I studied. It was pretty interesting. In the next 45 minutes or so, I'm going to talk to you about kidney transplantation. This is not going to be a clinical update type talk. It's going to be more about exciting things that keep us up at night and what the trajectory of where we're going with regard to sorting out what is the biological basis of disparate outcomes across race, especially in South Carolina is. Okay, so that's where my trajectory is going to be. Do have disclosures. I have grant support from Astellas and Novartis, and I am on a study steering committee from Novartis. Kidneys are important. If you are a human being, it's because you have kidneys. Isaac Dinesen, or Karen Blixen basically said this. What is man when you come to think upon him but a minutely set, ingenious machine for turning with infinite artfulness the red wine of Shiraz into urine? Most guys that have been on a boat in an afternoon know exactly what that means. Okay, so when those things fail, when those little kidneys fail, you have to go on these things called dialysis. Whether you do it with a machine or whether you do it with through the peritoneum, it's not fun. And the number of people that need dialysis keeps going up every year. The number of people that receive a transplant remains more or less constant. Okay. And that's a problem. So that means transplantation gives you the classic economic conundrum, where if you define economics as the science of allocation of scarce resources that have alternate uses, transplantation is it. So it is also a problem in terms of how much money gets spent on transplantation, and ESRD expenditures keep going up, and the projections through 2020 are $53.6 billion. Okay, The total Medicare expenditures for transplantation, so this is for end-stage renal disease, and if you break down end-stage kidney disease into patients who are on hemodialysis, peritoneal dialysis, and transplantation, the lowest expenses are actually with transplantation. The bulk of the money gets spent on hemodialysis patients, and it keeps going up every year. So, and if you look at total medical expenditures by Medicare ESRD expenditures per person by year, so it's not as if there's just a lot more hemodialysis patients and a lot fewer transplant patients. Per patient per year, transplantation is actually the economic treatment of choice. So clinical transplantation became a reality in 1954 when the first successful live donor kidney transplant was performed at the Peter Ben Brigham Hospital. And it was between two identical twins. The transplant surgeons on the left, transplant nephrologist in the middle, another transplant surgeon, indicating very well at that early time that it is possible that you need a team to make this happen. And keep that thought in mind. 50 years later, we all had this opportunity to witness this moment when the recipient had died and the surgeon was still alive, and the donor was alive, and this was in 2004 when at the American Transplant Congress, and this is a cell phone photograph. So let us just basically briefly review what is involved with the transplant. You sew in the organ, artery and vein. Things can go wrong at the ureteric anastomosis, stays in the right lower quadrant. Surgeons put it in. That's the end of it. The rest of it is us. It's medicine, okay? And it is medicine because what you end up having to do is to take care of the allograft, which is going to be attacked by the immune system, and is always in a sort of metastable relationship that you stabilize with a bunch of immunosuppressive medications. So antigen gets presented and interacts with the T cell receptor. Signals go to the inside of the cell. Transcription occurs. Growth factors get secreted. They act back on the cell. Proliferation of cells occurs. You need nucleotide synthesis. You need cell cycle regulators. And immune effector cells then can home in on the allograft. Interestingly, so what you see here looks like a lymph node. There are no lymph nodes really draining the transplanted kidney because you cut the lymphatics. So the first place where things actually occur is the spleen, and that's a very difficult site to sample. So what we do in conventional transplantation is to have a set of combination of agents used to suppress the immune system so that it can keep the allograft free from rejection and the host free from infection and neoplasm. The treatment that we use is extremely conventional. We use a calcineurin inhibitor. We use an IL-2 receptor or depleting T-cell antibody for induction. We use an antiproliferative agent, which is either mycophenolate mofetil, which inhibits purine synthesis, or we use sirolimus or everolimus, which are inhibitors of cell cycling pathways to be the mTOR pathway. And we use steroids in our program. And that's about as much as I'm going to talk to you about regimens at the beginning part of this talk. Our best outcomes have been with these regimens, and there's a huge bunch of controversy in the field as to whether you use steroids or not. As just a practice point here, I'd like to say that please don't monkey with steroids in practices. Even those 5 milligrams of prednisone are sacrosanct, and the effects that you'll see downstream occur about 3 years after you lost interest in the patient. The patient has forgotten that the prednisone was reduced. And typically you'll have recurrent disease of fibrosis without knowing what happened to the patient. Okay? So what happens when you use these regimens? What kind of GFRs do you end up with? Normal GFR, 100 ml per minute. End-stage renal disease, less than 10 ml per minute. Transplant kidneys, on average, with calcineurin inhibitor bearing regimens which constrict your afferent arteriole, give you an obligate 20% decrease in GFR, especially at higher levels on average. You'll get an adjusted 6-month eGFR of about 57.3. And if you notice, everybody has got their own opinion about what kind of regimen they want. More or less, you get the same thing. And that's because all of us regress to the mean. What nephrologists are really good at is trying to play the game in such a way that they get the best creatinine and the best eGFR for their patients. So absent any knowledge of what the body is doing to the drug which is pharmacokinetics, absent any knowledge of what the drug is doing to the body, which is pharmacodynamics. Aggregate data that we get from registries, which yield data like this, actually don't mean much. But just keep in mind that it's possible to use any kind of regimen and still get a decent result if you know what you're doing. The kind of kidney function that you get from a transplant determines your outcome. And primarily, the best outcomes from transplantation, the survival benefit of transplantation, is determined by freedom from cardiovascular disease. So before 1950, people died of renal failure. Belding-Scribner made dialysis a reality. And the first paper that came out within a year and a half was the whole business of accelerated atherosclerosis that occurred in these dialysis survivors, early dialysis survivors. They literally formed bone in their vessels because of perturbations of calcium and parathyroid hormone and other things, and phosphate. So if you have a great creatinine, which is less than 1.3 after transplant, your cardiovascular event-free survival is optimal. As your GFR goes down, your cardiovascular survival is worse. So what happens? So let us. I mentioned before that rejection occurs in allografts. It occurs in two forms. So the first form is what we call acute T-cell mediated rejection, where cells can traverse the peritubular capillary. They do the usual things of tethering, rolling, arrest, and the diabetes across. And then they get into the space called the interstitial space, which we really don't think about normally because most of the pictures that you see of kidney disease are about the glomerulus. And they go across a chemokine gradient, they go between the tubules, and they start destroying things because they secrete things like granzyme B and perforin, which are basically killer molecules, and you can see them on PAS slides like this as a lymphocyte sitting between two tubular cells, and this is called tubulitis. But that same phenomenon occurs inside a blood vessel, and it goes under the intima. It's called intimitis or endotheliitis. It's called a cell-mediated vascular rejection. Both of these things, if caught early, are canonically reversible. We like to say that these things are reversible, and the implication in the literature is that they may not be of consequence. Actually, nothing could be further from the truth. So usually these episodes are treated either with steroids or with depleting T-cell antibody. The early advances in transplantation, freedom from rejection, clinical survival, and clinical transplantation as we have it starting in the 1950s basically used azathioprine. Rejection rates were 50 to 60%. With the onset of cyclosporin, cadaveric transplantation became a reality in terms of the numbers that were performed. And what really ended up happening was with cyclosporin and azathioprine, folks basically got the rejection rates down to 40%. What happened with the introduction of mycophenolate mofetil afterwards was that rejection rates fell further, and now we should be seeing rejection rates that are really low. The downside to all of those things is that they predominantly target T cells because that's what was thought to be really important. More and more information is coming out saying targeting B cells and antibody in transplantation is important because B cells get activated, they get committed to proliferation, they proliferate, they go to the bone marrow, and they produce antibody, which is alloantibody that attacks the allograft. What does that look like? Antibody binds to endothelium, complement gets activated, mononuclear cells come in, polymorphonuclear cells come in, coagulation cascades get set off. It looks like little cells sitting inside peritubular capillaries, which is called peritubular capillaritis. They can sit inside the glomerulus, which is called glomerulitis, and complement activation can be found by staining for C4D, which is a complement split product that binds covalently to the basement membranes. You can target B cells and antibody by depleting B cells by using things like rituximab. You can take out plasma cells by using agents such as bortezomib, which we use off-label for myeloma indications. You can deplete antibody using plasma exchange, or you can use IVIG to block the effects of antibody, and you can inhibit antibody function using IVIG. And recently, there's interest in using inhibitors of the complement pathway, such as eculizumab. So that's essentially how you manage rejections. Okay. this is not really relevant except to show you that if you use agents to treat antibody-mediated rejection, it's important to catch these early. This is data from us showing that if your peak serum creatinine is less than 3 at the time of rejection treatment, you have a decent survival. This is 10 patients, so everything looks like a square. But if you have a creatinine that was greater than 3, you end up having a bad response in terms of survival. So it's not good to sit on these episodes for long. Be that as it may, if you're running your program right, the number of people that you treat for acute rejection should be around the 10 to 15% per year. Okay. The other problem that you have whenever you use immunosuppression is that if you drove your car the way we drive immunosuppression in the clinic, you would not have a car, you'd probably be dead, and lots of people would be dead around you. Because the way we use immunosuppression in the clinic is to have essentially have a little needle which tells you that's your drug level you need to go by. But most of the time, you find out about the event after it's occurred. So if you just looked at your speedometer and found out that you hit the lamppost after you hit it, it would be a problem. But that's the way we practice. And while we say that we look at these levels and so on, crudely put, we are an event-driven practice. Okay. So what happens with adequate immunosuppression to suppress the immune system is that you can end up getting viral infections such as BK virus, which can then look like they're in the tubules and look almost like rejection, and you have to do immunostaining or PCRs to find out. And it's possible to prevent these, but at the same time, you cannot live free of it. So one of the questions that came up in the mid-2000s was, why bother with a transplant? Well, you do need to bother with it because the longer you stay on dialysis, the more likely you are to die. So it's about a 25% annual mortality rate if you're more than 5 years out. And the longer you wait for a transplant, the more likely you are to have some kind of event. If you have preemptive transplantation, which is before you went on dialysis, you're less likely to have either a death or a cardiovascular event. Okay? So being longer on dialysis also impacts the way your immune system reacts. So those folks who have who've been on hemodialysis for greater than 36 months tend to have more T-cell alloreactivity. They tend to have more rejection episodes, and that's something to keep in mind if you think that dialysis time matters. Okay. Does transplant then really save lives? Is it worth putting a transplant in, going through the surgery? Is the patient more likely to die of transplantation than not? On average, if you look at time-dependent risk, the risk of the transplantation is outweighed by the benefit that you get on average after 3 months. It's very nice to put in a graph and say it's 106 days when you get when the relative risk of dying from the transplant equals the benefit of dying of the transplantation. That interval varies between 5 days and 514 days. So when we are looking at a patient in the transplant clinic, in half an hour, we have to make up our mind whether you have somebody whose risk is equalized in 5 days or 514 days, which is basically a 100-fold difference. And that's essentially where the selection becomes a difficult thing. So why does dialysis vintage matter? If you look at what happens to overall death and cardiac death by a dialysis vintage, and this analysis is already 10 years old, or 11 years old now. We did this sometime in 2004. If you look at what happens here, overall death accumulates over time. The longer you're in dialysis, most of this is due to cardiovascular death. A lot of it is infectious. If you look at what happens after transplant, your event rate really stabilizes. Cardiac death really goes down and doesn't start going up until after you've been on dialysis, transplanted for 60 plus months. That is in individual patients and aggregate data. If you look at what transplant does for society, and this is probably one of the most influential papers that's been written, that just came out 2 weeks ago, a very simple analysis where they looked at what happens to the survival advantage of transplant over remaining on the wait list for any organ. And what they found out was over the 25 years that records have been maintained in transplantation, 2,270,859, almost 3 million life years, patient life years, have been saved by transplantation, all organs. And the way it was done, and most of that survival benefit comes from kidney transplantation, which is 1.3 patient life years, okay? 1.3 million patient life years. So what they did was to compare the area under the curve of survival curves. It's elegant in its simplicity between living donor transplant, deceased donor transplant, and waiting list, and basically calculated the benefit that you get out of transplantation. Profound stuff. So we talk about the benefit to the recipient. What about living donors? So if we showed you that transplantation rates have stayed relatively constant, so if you have to move the needle on more people getting transplanted, you need to have more living donors. Is it safe for the living donor? On average, if you select your living donor properly, the patient's not fat, the patient's not diabetic, the patient's not hypertensive, he's not a smoker, the living donors and normal controls have about equal survival. There's some data suggesting that in related donors, if screening things are not, if screening is not inadequate, or if there's a shared risk factor, then there may be some cause for concern. On average, if the screening processes are good, we would expect that living donors do well. So if you look at what's happening to living donation, the number of related donors has more or less come down. Unrelated and directed donations are going up in this country, and there's been some concern about the rates of living donation after the economic downturn, because people's uncertainty about where they are with their jobs and insurance and everything else. And so this is something that the transplant community is fairly concerned about. So how does one optimize living donation? And and how do you overcome barriers to compatibility using paired donation? So if you talk to people have very, very disparate notions about whether they're compatible to someone else. So you'll find highly educated people who think they know blood group compatibility, they think they know tissue compatibility, and oftentimes we find when somebody says that they're incompatible to each other, it may even be a ruse to say, listen, I really don't want to donate. I'd love to do it, but I don't feel like it. And so, but be that as it may, one does need to overcome barriers to compatibility, because you could be married to a spouse who is not compatible to ABO in the old days, or the husband may be donating to a wife and find out that they're sensitized by pregnancy. In the old days, you had to just go ahead and do plasmapheresis and IVIG and all kinds of things to get this transplant done. And those transplants last on average about 3 years with a rejection rate of about 70%. So comes paired donation. So how does it work? So if you take somebody who's got recipient 1 and wife of recipient 1, they're incompatible to each other because of cross-match. Wife of recipient 1 may donate to recipient 2, and brother of recipient 2, who's incompatible by blood type, may donate to recipient 1. So that's a simple, two-way swap. But if you look at it in terms of what can happen societally, then it brings to you why some people get Nobel Prizes. So Alvin Roth used cooperative game theory to study different matching methods. And before he invented the kidneys the chain kidney donations, he had actually invented the National Residency Matching Program. All of us are familiar with NRMP. So he's one of the inventors of that. And within the framework of this theory, it is important that a stable match is found. And he used a lot of theoretical results from the market. So it starts off with a good Samaritan donor, who then goes on to receive, and it starts and who goes on to give to a recipient, and then that person's donor then gives to another recipient, and chain starts off, and it can terminate by giving the list. So if you take this to its ultimate degree, you can then start shipping kidneys across the country, within the coasts, and if you do this, your median, since it's a living donor kidney, almost all of them have no delayed graft function. The median 1 week creatinine graft shipped coast to coast at 1.6 milligram per deciliter, similar to those not shipped across the coast, which is 1.5. Okay, so we have a robust kidney paired donation program that has contributed to chains and simple exchanges. We've performed 18 transplants to date through the program inception 2 years ago. We're increasingly focusing on this being a mode to promote living donation in the region. We're also doing this in the context of a multidisciplinary care and outreach program. We have excellent outcomes despite a poor population health in South Carolina, and we've been in continuous operations in 1968 since Fitz and Raja began the program. Our current volume is 180 to 220 kidney transplants per year and 12 to 15 kidney pancreas transplants per year. And we actually have a unique care program that delivers excellent outcomes, and we have won multiple accolades from UHC. So if you look at the way transplantation differs from the rest of medicine, it is that there's a huge amount of transparency with regard to how outcomes are plotted. You can go now on the web and look at our outcomes. Our outcomes are as expected for both living and deceased donors, for both 1 and 3 year patient and graft survivals, which is a good place to be. In addition to that, our length of stay compared to all other transplant centers is really low, and our rates of DGF are also low. Delayed graft function are very low compared to other transplant centers. 30-day readmits similarly, and through recent practices, our DGF rates are fairly low too. Our in-hospital mortality is excellent compared to all other transplant centers, and we also have some of the lowest costs in the country. Okay. Outcomes matter. If your outcomes drop, transplant volume will drop. If you have a low-performing center, transplant volume drops. Okay, so it is really critical to maintain performance. It also turns out that it's not just graft and patient survival, how patients feel about you. We all laugh about HCAP surveys sometimes. We looked at this recently, partly funded by the Srinivas Family Foundation grant. A kidney transplant center with patient satisfaction scores above the median was 69% less likely to have below average reporting of performance by the scientific registry for 1 month observed to expected survival event rates. For 1 year graft event rates, kidney transplant center with high patient satisfaction scores was 36% less likely to have low SRTR reported outcomes for observed to expected survival event rates. So where are our unmet needs? So this is what most people do. So if you're running a program, you're always about your survival. You're always about your statistics. So what can we do at MUSC that's unique? What is unique about our population? What are our unmet needs? Where can we make a mark? Okay. So let's see what has been happening. I told you that rejection rates have been going down, but has that affected long-term graft survival? If you look at rejection rates over time, they've been decreasing. But if you look at the relative risk of graft failure, that's rate of long-term graft failure, that has stayed essentially constant. So what could be happening? Dr. Nankiewicz from Australia published this paper, which is first seen in the New England Journal of Medicine, and this is a subsequent iteration that was published in Transplantation. What he showed that over the years after transplantation, cyclosporin dose keeps coming down, levels keep coming down, but over time what he noted was that on protocol biopsies, early on there was acute cyclosporin nephrotoxicity. As you went out more from transplant, almost everybody had 100%, had some kind of toxicity. They labeled anything that was thickened arteriole as toxicity. And essentially, they had 90% graft survival. They had no control group. So the question came, is it a good thing? If you don't have a control group and these people have 90% 10-year graft survival, that's probably a great thing, right? So, and the other problem is that there's growing realization that anything that's fibrotic in the allograft doesn't necessarily mean that it's drug toxicity. So Dr. Posadas from our group and David Tabor looked at this in terms of what happens if you decide that Dr. Nankiewicz is right and you start reducing immunosuppression. So we looked at what happens to people when you start reducing immunosuppression for either infection or cancer or some other event. So early on I said, we use immunosuppressive medications, but we don't really measure a person's state of immunosuppression. So our adjustment of drug doses is based on levels obtained during therapeutic drug monitoring, which is basically monitoring of trough levels. And most of our titration is event-driven, either rejection, infection, neoplasia, or intolerance. So the question was, what is the phenotype of kidney transplant recipients who had immunosuppression reduction, either due to infection or other intolerances? So if you look at the survival graph, where we have people had no immunosuppression reduction, had immunosuppression reduction for intolerance, or immunosuppression reduction for infection, those folks had a rejection-free survival that was inferior to those that had no immunosuppression reduction and continued their immunosuppression uninterrupted. If you looked at Dr. Nankival's graph, you would think that if you lowered immunosuppression, you should have less toxicity. Toxicity chronically of cyclosporin or tacrolimus would manifest as interstitial fibrosis and tubular atrophy, which means on a survival analysis, you would want to see interstitial fibrosis and tubular atrophy, which we abbreviate as IFTA or IFTA, free survival. That's optimal, right? So if you look at the people that had no immunosuppressive reduction, they had the best interstitial fibrosis and tubular atrophy free survival. If you reduced it for intolerance or for infection, you actually ended up having more interstitial fibrosis and tubular atrophy over time. So the key take-home message were that factors associated with immunosuppression reductions included African American race, various recipient comorbidities, marginal donor characteristics, depleting antibody treatment, probably relating to BK virus infections, and delayed graft function. So, and also this reduction was associated with increased incidence of interstitial fibrosis and tubular atrophy and chronic allograft changes, which are remote from the time of onset of the immunosuppressive reduction. So we could not really, there was a huge amount of variability in terms of that, but most of the time it's remote. So the better methods to measure the net state of immunosuppression are needed to deliver optimal immunosuppression in the clinic. So one of the things that struck us was there's a huge racial disparity in what happens. So it is typical in transplantation to have a column. Table 1 in any transplantation paper is what are the demographics of your population, how many whites, how many African Americans, males. Dogma, African Americans, more rejection, less infection, great survival, high variability of drug outcomes. This is there in any textbook article that you see will tell you African Americans have variability in drug levels. So what happens when we look at our population? So if you look at, these are basically Cox regression plots of event-free survival for acute rejection and interstitial fibrosis and tubular atrophy, compared across FK expo. FK is tacrolimus exposure, and that is by trough levels, and these are stratified by race. Let's look at the non-Africans first, and let's look at acute rejection-free survival. If you have, among non-African Americans, the relationship between rejection-free survival across a range of trough levels of less than 8 or greater than 8 is very tight. So they have rejection-free survival that's pretty good. If you look at interstitial fibrosis and tubular atrophy free survival in the non-African Americans, if you have a mean FK that's maintained around 8, it stays, they do fine for the most part. If they're less than 8, they get into trouble with more fibrosis, which mirrors what you saw in the previous graph. Among African Americans, this relationship is not as tight for rejection as you'd see with the non-African Americans. And so that brings to question as to how do you optimize drug exposure across race, and what are the other determinants that go into this? Okay. So that then boils down to what we as transplant nephrologists regard as our trade craft, which is what is the real determinant of what is a concentration effect relationship. In other words, we expect that rapid clearance of tacrolimus will affect attainment of therapeutic levels. We know that there are certain SNPs which make people express CYP3A5 in the gut epithelium, which makes them clear tacrolimus fairly rapidly. They require usually double the dose to achieve a therapeutic level at a given time. And those SNPs are much more common in African Americans, and those are called expressor patients or an expressor phenotype. And we expect that poor clearance of tacrolimus from the kidney could increase its toxicity of the kidney, which is essentially maintained by the proteins in the P-glycoprotein complex. And we expect that genes that determine renal progression, and let's, for the purpose of this talk, we'll say there's an apolipoprotein L1 risk genotype, which would affect progression of renal allograft functional attrition after a variety of insults. In transplantation and in nephrology in general now, it's impossible to have a talk without some discussion about the ApoL1 gene and what it does to renal survival. So apolipoprotein L1 confers a survival advantage if it's in the heterozygote to people of West African descent from trypanosomal infection. But when you have both copies, you end up having a situation where you have glomerular disease, especially when FSGS type phenotype. So this is from Wake Forest, where they looked at the non-risk genotype versus the APOL1 risk genotype, control for rejection, and found that independent of rejection, those people who had the risk genotype had rapid progression to renal failure. We then said, can we look at this in our population to see not only look at the APOL1 effects, but also look at it in terms of recipient CYP3A5 and donor P-glycoprotein to see what happens to fibrosis and atrophy. We had 200 patients previously enrolled in a prospective randomized risk-stratified comparative effectiveness study comparing two different induction treatments who received fairly stable immunosuppressive regimen between 2005 and 2012. And these were all adult primary or repeat solitary kidney transplant recipients. We then genotyped the recipients for CYP3A5, the donors for ABCB1, and we looked at and the donors and recipients for ABCB1 and the donors for APOL1. We know the recipient APOL1 genotype does not really matter. Patients were grouped based on the presence or absence of the aforementioned SNPs and homozygous or heterozygous. And patients who are homozygous or heterozygous for the wild type are grouped and compared to patients that are homozygous for the SNP of interest. And then we compared them for all kinds of demographics, transplant characteristics, and outcome. And for the CYP3A5 and PGP SNPs, the predominant outcomes of interest were biopsy-proven acute rejection or the development of interstitial fibrosis, tubular atrophy. We then looked at the severity of neurotoxicity, hyperkalemia, other effects of toxicity such as renal tubular acidosis, new onset of diabetes after transplant, patient graft survival. For APOL1, what we looked at was the incidence and severity of progressive renal dysfunction, including the development of interstitial fibrosis, tubular atrophy. We then compared severity of slope change in GFR, incidence and severity of proteinuria, and patient graft survival. So if you look at baseline characteristics of the PGP and CYP3A5 genotypes, for the donors, we made comparisons for the PGP, as CYP3A5 variants in the donor kidney are not likely to impact outcomes, and patients were grouped into high tacrolimus cohort, if the clearance cohort, if they express both the ABCB1 SNP, which is called 3435 non-TT, and a STAR1 gene variant, which basically makes you a high tacrolimus clearer. In other words, you throw out your CYP3A5 because you're expressing, or you throw out your tacrolimus because you're expressing CYP3A5 in the gut, you throw it out because you're a high expressor of ABCB1, which is the P-glycoprotein as well. Okay, and we've noted that the baseline recipient demographics were similar, with the exception of diabetes. Recipients that received donor kidneys expressing the 3435 TT were less likely to have a history of diabetes. We don't have a ready explanation for this. Recipients were well matched, except that they had a history of diabetes more often. So if you look at clinical outcomes, expressors of the low PGP expression were significantly more likely to experience moderate to severe IFTA on follow-up biopsies, which trended towards significance. And low PGP expressors also trended towards a higher incidence of overall infections. In other words, could it be that if you express your P-glycoprotein in the kidney at lower levels, you're clearing tacrolimus locally at much lower rates, at a rate that you cannot predict with the peripheral blood level alone, which could cause local toxicity, either by modulating what happens in terms of infection or pharmacodynamic effects in terms of toxicity. Okay. So, and recipients that had high tacrolimus variant signatures were nearly twice as likely to have low tacrolimus levels and significantly less likely to have high levels of drug. And they also had 3 times the incidence of biopsy-proven acute rejection, 25% versus 9%, and nearly 5 times the rate of developing stage 4 CKD by study end. Okay, so that's an important one. So if you look at the survival curves, this is what they look like. So if you look at the 3435 TT variant for ABCB1 or P-glycoprotein, which makes you not clear tacrolimus from a kidney, you end up having worse interstitial fibrosis and tubular atrophy over time. If you have the gene that allows you to clear tacrolimus, you end up having a better fibrosis-free survival. If you look at recipients, those that don't express the CYP3A5 achieve therapeutic levels, stay free of rejection. And if you look at CYP3A5-1, which is the expressive phenotype, they end up getting more rejection. So what happens if you look at it in terms of what we will call risk genes within the kidney, prototype of which is the apolipoprotein L1 gene. So we noticed on these analyses that the L1 risk genotype kidneys were more likely to be of female origin, have a history of heart disease, but not necessarily have a history of hypertension. Okay? And when we looked at clinical outcomes across the ApoL1 genotype, the risk of graft loss was significantly higher among recipients of ApoL1 genotype kidneys, which was confirmed with multivariable analysis. Other clinical rejection outcomes include acute rejection, interstitial fibrosis, death, and borderline rejections were also similar across the groups. Okay? So if you look at the survival curves, if you look at the risk variant, we replicated the results of what was seen by the Wake Forest group, where you have a threefold higher risk of graft failure if the donor kidney has the ApoL1 risk variant. And if you look at what happens to the clinical phenotype across ApoL1 risk variant states, what we noted was the mean blood pressure was higher in these people. Mean blood pressure of greater than 130/80 was much more highly prevalent, but it didn't really come to statistical significance. The spot urine was, I misstated that. They were more or less, the blood pressures greater than 130, but less than 140 were more or less equivalent. If you looked at proteinuria, it was not very different. So nephrologists love to dip urine and look at proteinuria. But if you start going into the biopsies, if you look at what happens to glomerular lesions, almost 4 times higher incidence of glomerular lesions the moment you had a donor ApoL1 risk variant. The FSGS lesion was present with any other kind of injury that you see in the allograft. It was present much more commonly in people that had the ApoL1 risk genotype compared to those that didn't. And this is something that we are fairly excited about. So what we're concluding based on this is that kidney transplant recipients with gene variants for high tacrolimus clearance are at higher risk for early acute rejection, potentially due to low tacrolimus exposure, and gene variants for low PGP expression in the donor organ may be a factor for graft fibrosis. So this could lead us to donor and recipient genotyping, which may allow clinicians to prospectively individualize tacrolimus regimens in recipients and optimize outcomes. And donor ApoL1 genotype associates with a more aggressive clinical phenotype and increased risk of graft loss. So what we think is that if you have a risk genotype, you may polarize towards a maladaptive glomerular pattern of injury and mediate progression of graft loss among kidney transplants, and we need to study this further. Our sample size is not large enough to study all the other two-way interactions that you want to study. So what we're going to do, the first thing we're doing based on these results is that we're going to put together a clinical protocol where we genotype recipients with CYP3A5 to determine tacrolimus dosing so that we achieve optimal dosing. Vanderbilt already has a program built into EPIC, which tells you what to do. And then we need to do a larger study where we're actually going back into paraffin blocks and genotyping patients. So the other things that we're doing are two very exciting things. One is actually a investigator-initiated protocol that where we are studying the relationship between what happens to lowering tacrolimus exposure and maintaining adequate immunosuppression using concentration-controlled use of mTOR inhibitor, everolimus, in the context of our clinical protocol that includes protocol biopsies at 3 months, 1 year, and 2 years, where the patients will be randomized to a low-intensity tacrolimus with everolimus or standard of care. They'll get, after a protocol biopsy at 3 months, they'll be biopsied again at 1 year and 2 years, which is part of our standard of care. And they'll be getting fibrosis scores on the biopsy as also measures of fibrosis, of biomarkers and pulse rate velocity, and this will be repeated 2 years. We're planning to recruit about 60 patients. We're up to about 38. Should be done by the end of the year. Okay. So what I want to share with you in conclusion is the excitement that exists on 6 East, which is our transplant floor, where this bell essentially is a ship's bell donated by David Ploth and rings in every new transplant. And what we hope to deliver throughout the state are outcomes such as this, where I met this lady in Greenville Clinic. She got her transplant in 1987. She's 88 years old at this point. And this resident was born in 1987 and was rotating through the transplant clinic. And I thought this would make a good photo op. And it takes a team to get this done. One of the happiest things for me here is to be here at MUSC and to be with this wonderful team. We have a team of nephrologists, Prince Mohan, Dr. Posada Salas, Dr. Salazar, and our surgeons include, and this is a photograph taken at our retreat, which is, I can assure you that we were absolutely sober. A lot of us were on call, and this was on a Saturday afternoon. And we have some fantastic surgeons and a wonderful set of nephrology fellows will light this up when they graduate. And we have an absolutely fantastic group of advanced practice providers who work with PharmDs and coordinators, and a group of nurses in the clinic. And this is getting cut off in the bottom, but a lot of what I showed you would not have been possible without robust collaborative relationships with the Department of Surgery and David Tabor in particular, who helped us tremendously in jump-starting a research program within the Division of Transplant Nephrology. Thank you very much. If there's any questions, I'll be happy to take them.